We will be looking at diuretic agents and their therapeutic use. We will also review the anatomy and physiology of the renal system. As a rule, diuretics are designed to increase urine output by eliminating excess fluid from the body. And reducing this extra fluid, they also reduce blood pressure. The major groups of diuretics we will be discussing are osmotic diuretics, carbonic anhydrase inhibitors, thiazides, loop diuretics, and potassium-sparing diuretics. Now let's review the anatomy and physiology of the kidneys. As we know, the kidneys are paired organs found behind the abdominal cavity on either side of the spinal cord. They are perfused by the renal artery and receive the highest blood flow per organ weight of any other structure in the body. They account for approximately 22% of the body's cardiac output, and like the heart and brain, are active organs, not passive filters. The functional unit in the kidneys is the nephron. It is composed of the glomerulus, proximal tube, loop of Henle, distal tubule, and collecting duct. Let's look at the glomerular filtration first. Glomerular filtration occurs in the glomerulus, which is mostly comprised of an ultrafiltrate with a tiny amount of protein. It is the same ionic concentration of plasma, containing sodium, chloride, and bicarbonate. Most of the glomerulus filtrate is reabsorbed in the tubules, approximately 99%, and 1% of this filtrate is excreted as urine. For most adults, this results in urine output of 30 to 60 milliliters per hour. If less than this amount, we refer to it as oliguria, and greater than this amount as polyuria. Diuretics interfere with this reabsorption in the tubules. As stated before, the main ions that are part of this reabsorption process are sodium, Na+, chloride, Cl-, and bicarbonate, HCO3-, with potassium, K+, being an additional ion that is reabsorbed. Most of these ions are reabsorbed in the proximal tubules, with sodium being the primary electrolyte which influences water being retained or excreted. The kidneys are also integral to acid-base balance, with sodium also being the crucial ion in this process as well. If either chloride or potassium are low, then sodium is exchanged for a hydrogen ion, producing a loss of a hydrogen ion, which leads to metabolic alkalosis. If bicarbonate is prevented from being in the infiltrate and forming carbon dioxide and water, then this loss of bicarbonate leads to metabolic acidosis. The primary goal of all diuretics is to reduce extracellular fluid volume, ECFV, which is often seen in congestive heart failure, and by reducing this volume of fluid, blood pressure may also be reduced. This is achieved by preventing sodium entry into the tubule. Keep in mind that for diuretics to work, sodium chloride output must exceed sodium chloride intake. We will now discuss the groups of diuretics and where their area of action occurs. Osmotic diuretics such as mannitol, glycerol, and urea reduce the reabsorption of water and solutes in the proximal tubule and descending loop of Henle, resulting in a loss of potassium ions. These agents are used to treat acute renal failure and cerebral edema, which often occurs in traumatic brain injury. Mannitol, under the brand name Aridol, is also used for bronchoprovocation during PFTs, to diagnose asthma in patients 6 years and older. The next group of diuretics are carbonic anhydrase inhibitors. They are considered first-line treatments in patients requiring more aggressive management, including patients with higher intraocular pressures from glaucoma, patients with mountain sickness, and patients with cystinuria, which is increased urine pH. Examples of these drugs are acetazolamide, methazolamide, and dichlorophenamide. The area of action is the proximal tubule, and they work by reducing sodium and bicarbonate reabsorption. A common complication of this group of diuretics is decreased potassium. Other indications are as adjunct therapy for epilepsy because of their ability to treat periodic paralysis and in hydrocephalus. Let's look at our next group, loop diuretics. These are commonly seen in the ICU, and examples are furosemide or Lasix, bumetanide or Bumex, and toracimide or Demodex, and they are the most potent diuretics. They work by inhibiting sodium, potassium, and chloride from being reabsorbed in the loop of Henle. They also cause an acute vasodilatory effect. They are indicated for hypertension, congestive heart failure, both acute and chronic renal failure, ascites, and nephrotic syndrome, which results from damage to the blood vessels in the kidney. They are also called high-ceiling diuretics because they cause up to 20% of NaCl and water to be excreted. As therapists, we most often see them in the treatment of pulmonary edema, but may also be used in hypercalcemia, renal transplants, and to enhance urinary excretion of chemical toxins, such as lithium, amphetamines, or aspirin overdoses. Our next group of diuretics are thiazides, which inhibit sodium chloride reabsorption in the distal tubule. Examples in this group are chlorothiazide, hydrochlorothiazide, and methoclothiazide. They are indicated as a first-line treatment in mild hypertension and may be used in congestive heart failure, hypercalciuria, nephrogenic diabetes, and chronic renal failure. They have a narrow therapeutic range, and therefore there is an increased risk of toxicity from their use. The last group we will discuss are potassium-sparing diuretics, which are marketed as spironolactone or aldactone and eplerenone or Inspira. They block aldosterone in the distal tubule, effectively also blocking exchange of sodium for potassium and hydrogen ions. Medications in this group are used to treat chronic liver disease, such as cirrhosis, hyperaldosteronism, most often caused by adrenal tumors, and renal artery stenosis. Because they are potassium-sparing, they may lead to hyperkalemia, which can induce life-threatening arrhythmias. The most common side effects for diuretics are hypovolemia and acid-base disturbances, as previously mentioned. Hypovolemia usually manifests as dizziness, extreme thirst, and excessive dryness, decreased urine output, dark urine, and constipation. Other adverse effects are hyperglycemia, often seen in thiazides, and ototoxicity, most commonly seen in loop diuretics. Diuretics are not recommended for pregnant or nursing women as they can dehydrate a baby, but can be used in children in smaller doses, with furosemide or Lasix being the most effective and least toxic. In respiratory care, we may see diuretics as adjunct treatments in ARDS when edema is present, and the effects on decreased pulmonary capillary wedge pressures also improve survival. They may also be used in chronic lung disease of the preterm infant. In this case, furosemide is aerosolized for short-term use.